Hi, everyone. Welcome to our next conference session, which is titled Approach to Secondary AML. Thank you for joining us. I'm Lee Clark, Director of Patient Services. As we get started, I'd like to recognize the generous support of our corporate sponsors, Alexion, Apellis, Amogen, BioCrest, Bristol-Myers Squibb, Genentech, Novartis, Regeneron, Servier, and Tahoe Oncology, and the generous support of our patients, families, and caregivers who without their support, this conference would not be happening today. Immediately following the presentation, there will be a question and answer session. If you're participating online, feel free to submit your questions at any time using the Q&A icon on the engagement panel to your right. To submit your question or comment, just type in the Q&A, hit enter, and we'll be asking your questions at the end. And we'll also be asking the questions here in the room for those participating in person today. When asking questions, I do ask that you do two things to help us manage the incoming question. If you're online, please submit your question all at the same time. And second, for everyone, please don't share any private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Nathan Punwani. Dr. Punwani joined Mayo Clinic in October of 2021. He earned his medical degree from Drexel University College of Medicine and a master's degree in public health from Harvard University School of Public Health. He specializes in bone marrow transplantation, leukemia, lymphoma, and other blood disorders. It's my pleasure to welcome Dr. Punwani.
Okay, well, thank you for having me here. So yes, I'm Dr. Nathan Punwani, and I'm going to be talking about secondary AML. And I'm here at the Mayo Clinic, Arizona, where I specialize in bone marrow transplantation, oftentimes for secondary AML, and other myeloid malignancies, even for non-transplant care. So thanks for joining us this Saturday morning. Secondary AML, so this is acute myeloid leukemia, and it's secondary. It's secondary to something, right? It had to evolve from something, right? So before we get into secondary AML, the biological insights behind it, the therapies that we're giving as part of the armamentarium against it, as well as kind of the emerging therapies along the horizon in terms of battling this disease, let's talk about secondary diseases and how they evolve. And I think before we start off into getting to the nitty-gritty of this, let's talk about something a little bit fun. Let's talk about dinosaurs for a second. So I know it's kind of unusual, right? But it's a good way to start off a Saturday morning, and actually it's a good black box view of understanding how AML evolves, how it comes from some other disease or some other abnormal bone marrow process. So like a lot of evolution, natural selection, you have an environment. And that environment selects for certain traits. Certain traits, are given an adaptation to a particular species or organism so they can thrive. And then they pass on those same traits to the next generation and then to the next. And the same thing actually happens in our bone marrow. The same kind of selection and extinction happens in our bone marrow, just the way the leaves on a tree might give an advantage to these long neck dinosaurs, and then they pass on the genes of the long neck to the next generation of long neck dinosaurs. The same thing happens in our bone marrow. We have a certain environment. You have stem cells in that bone marrow that thrive in that environment. Every now and then the environment changes or some mutations happen that might cause the stem cells or some group of them to branch off, to break off. They might have some kind of extra level of fitness that gives them an extra advantage. And sometimes it comes at the expense of the other cells. Sometimes the environment in the bone marrow selects against those cells. And you end up having over time with enough mutations, some of these cells growing at a more deregulated pace, they grow at a more aggressive pace, and that's how you get secondary acute myeloid leukemia. So with that analogy, understanding kind of the black box view of kind of the underpinnings of secondary AML, we'll start kind of into what happens in our blood. So we have many different blood cells. You have white blood cells, you have platelets that help prevent and control bleeding. You have, like I mentioned, the white blood cells that help fight infections. You have red blood cells that, help diffuse oxygen and allow for oxygen to be transported to all our different organs. And they all have to come from somewhere, right? So they come from stem and progenitor cells in our bone marrow. We have bones inside those cavities. If anyone's eaten bone marrow, you'll see that there's a big cavity, and that's home to a lot of nerves, fat, neurons, a lot of other tissue, and stem and progenitor cells. And those stem and progenitor cells go through many different levels of maturation before they become these white blood cells, red blood cells, and platelets. Now, why is that important? So this is the hierarchy. This is kind of the family tree of what happens in our bone marrow every day. We have long-term stem cells that live with us forever, as long as we're alive, ideally. And then these long-term stem cells, about 1% of them on a given day become short-term stem cells. About 5% of those become the next level of progenitor cells. And down the family tree we go down. And then they'll eventually go through other successive stages of maturation, and then they become our platelets, our red blood cells, and then our white blood cells. But what happens with secondary AML? Some mutations happen. Most of the time the mutations are benign. They're just passenger mutations. Nothing really comes of it. They confer no clinical change, or they're clinically inconsequential. And most of our stem cells in this bone marrow, they're nice, diverse, but something happens that might cause some of those cells to branch off and break off, and then they become more aggressive over time as additional mutations happen or additional changes in the environment of the bone marrow happen. So that's what secondary AML is. It's acute myeloid leukemia that originates from some underlying stem cell disorder, some kind of stem cell problem. So there's many different, it should be MPN, but there's many different disorders that happen that can lead to AML down the road. So this is a bunch of, it might seem to you guys a lot of alphabet soup going on, but what myelodysplastic syndrome is one factor that can lead to AML down the road. So it's a disorder in which you have an increased number of immature cells that fail to divide and produce normal red blood cells, white blood cells, platelets. People develop low blood cell counts as a result, and then over time that becomes leukemia. It's also accompanied by a lot of morphological aberrations. So some of these cells that you look at the bone marrow, they just look very abnormal when you look at it with a naked eye. Some people have a myeloproliferative neoplasm. So these are a situation where the bone marrow might have certain mutations in it that causes more mature cells to be produced in a more deregulated fashion. So people have increased number of red blood cells or increased number of white blood cells and platelets, and they have this disease for several years, maybe even decades, and then more mutations happen that lead to what we call secondary AML. Then sometimes you have a little bit of both. You have some MDS and you have some MPN that both go along with it and can be seen on the bone marrow. And then other times people have what we call therapy-related disease. They have a therapy-related MDS, or they have a therapy-related AML, or maybe they have the therapy-related MDS that then becomes AML. And that's mainly because they have received past chemotherapy or past radiation for maybe some other cancer, and that's what leads to their diagnosis of acute myeloid leukemia, and many times it happens like 5 to 10 years later. And how are these diagnoses made? It's usually made with a bone marrow biopsy, and the bone marrow biopsy, just with pathological review, the pathologist is able to tell us that there's a lot of background aberrancies that are seen, a lot of the shapes, the sizes, the look of the cells, they look very dysplastic or abnormal. And that's where you get hints that, oh, this patient might have had MDS all this time, and then now it's because of increased number of leukemia cells accompanying that diagnosis, they have this secondary AML process that goes with it. Sometimes people have from the bone marrow, you'll get a lot of insights. We'll also order a lot of other accompanying studies. We'll do cytogenetics, where we actually culture out the cells so we can look at the chromosomes, and based on the chromosomes, we'll see if there's certain classic related aberrancies that will give us this diagnosis of secondary AML. The blast percentages usually have to be 20%, so that's like the leukemia cell percentage has to be 20% to call it this diagnosis. And then we'll also run now a myeloid next generation sequencing panel on that bone marrow biopsy to further delineate the genetic taxonomy of this leukemia. So ultimately, this prognosis can be pretty tough because this tends to be very chemo-resistant. And the reason why it's so chemo-resistant is there's a lot of genetic and chromosomal abnormalities. And it's those abnormalities, it's those mutations that cause the leukemia and make the leukemia more aggressive. And because it's more aggressive, as a result, the simple hitting it with a blunt cudgel with chemotherapy oftentimes tends to be refractory, especially the more traditional chemotherapies. So it tells us we need to do something more for a lot of these patients rather than just traditional chemotherapy. But yes, it's these genetic and chromosomal aberrations that give those abnormal stem and progenitor cells that extra survival advantage to just break off, and that's how they become and evolve into leukemia. And ultimately, what you have to do is whatever therapy you pick one with the highest benefit risk margin, so something that keeps the side effects low while maximizing the chances of complete remission. How we define complete remission is less than 5% blasts or less than 5% leukemia cells. But now we also realize that complete remission isn't always so complete. We have now more sensitive studies that we can order on the bone marrow biopsy when we're trying to determine if a patient's responded to therapy. And now we'll do some studies called minimal residual disease. Many times it's a flow cytometry study, but the idea is that it can detect leukemia at percentages below that 5% threshold. So it can do it at more sensitive gradations below that 5%. So it can go down to sensitivity, depending on the assay, of 0.01% to 0.1% leukemia. And we know the lower the better. It's like limbo. How low can you go? You give treatment, and then you want to make sure that when you repeat the bone marrow biopsy, yes, under 5% you're in complete remission, but if you can go lower than that, and what we get is something that's negative, so less than 0.1%, then you have the best outcomes for yourself. And we'll many times then consolidate with a bone marrow transplant, allogeneic stem cell transplant. So this is some of the genetic landscape of secondary leukemia. So one of the biggest causes of secondary leukemia is actually myelodysplasia. That's one of the leading causes, and usually the median age of incidence in the 60s and 70s. And you can see there's so many different mutations out there, and that's why we'll run on the bone marrow. We'll do a FISH panel. We'll also do a next generation sequencing panel, so we can outline and really identify all these mutations that could be out there, that could be culpable, that gives this survival advantage. And hopefully we can even use these insights to pick the right therapy for patients and have a more personalized approach to their medicine and to their care. So it's really not so much important to kind of know, for I think patients to know the individual mutations and what they do, but just to give you an idea of how diverse this disorder is. There's probably a lot of different genetic driver mutations behind secondary AML, which causes maybe their MDS or their MPN to branch off and become this AML. And then it's probably just not just any one mutation, it's probably multiple mutations cooperating together that leads to the secondary AML and makes this a tough diagnosis to treat, to grapple with, and then to ultimately defeat. Some other interesting insights that we've learned over the years, that secondary AML, it's not always the genetics. I know we see so many genetics here, right? You see dozens of different mutations, right? But then we're also realizing, compared to other cancers, so say like melanoma, skin cancer, when it comes to other diseases like lung cancer, you don't actually see as many mutations in these more myeloid disorders, so like in MDS and AML, compared to the more solid organ cancers. And that actually tells you that maybe it's not just genetics after all. It's a part, but maybe not the entire picture. It probably is other things like a very inflamed bone marrow microenvironment that maybe causes transformations in the bone marrow that selects against most of our stem cells and selects in favor of that aggressive, angry, pre-leukemic stem cell. So I think that's kind of just some other insights, and for the sake of time, I'll kind of pass these slides. But I like to outline the old ways of doing things and some of the new ways of treating secondary AML. So after you've done your diagnostic bone marrow, you have to treat these patients. Historically, we've always divided between our patients less fit or fit. If they were less fit, and keep in mind, the secondary AML, especially from MDS, is the median age of incidence is around 70. So a lot of patients have by then a lot of other comorbidities like heart attacks, strokes, diabetes. So we'll have to do many times pick this therapy, which is the classical mainstay since the late 2000s has been azacitidine or decitabine for less fit patients. And what they do is, classically, it's believed that these have an anti-leukemic effect by activating our own body's natural tumor suppressor genes, tell those cells to stop growing so much. But we also know there's some other alternative mechanisms for why this therapy can be effective. It also helps create this more pro-immune response to get our own immune system to eradicate the leukemia. It also encourages the most fit and the least genetically corrupted stem cells and to pick up the slack and produce more red blood cells, white blood cells, and platelets to overcome this leukemia that's crowding out everything. But unfortunately, the response rates of these single agent therapies are only about 20%. You also sometimes get some improvement in blood cell counts. These treatments also are slower to work, many times takes 4 to 6 months. Very sensitive. So that's where we did traditional chemotherapy for fitter patients who can tolerate kind of a high risk, high reward approach. We usually gave 7 days of cytarabine and 3 days of an anthracycline like idarubicin chemo or daunorubicin. And, unfortunately, even with this more blunt cudgel approach, we were only getting 20–40% response rates compared to people who are younger, who had de novo AML, AML that doesn't originate from anything else. It just happened all of a sudden. You get response rates of at least 60%. But for older folks and patients with secondary AML, we got less responses. So this is like the new way of doing things. And for kind of the fitter, older patients, there's a new chemotherapy that's been out since like around 2018. It's called Vyxeos. It's this 7+3, the cytarabine and anthracycline, but it's packaged up in a fat molecule so it has better penetration and durability of response. And they've compared it to traditional chemotherapy, and it showed that it prolonged overall survival by almost 4 months. The remission rates were almost 50% compared to around 30% for the people who got the traditional chemo. But a lot of the post hoc, so kind of the after the fact analysis has come out that suggests that the reason why patients have better long-term outcomes with Vyxeos chemo as opposed to the traditional chemo was because patients had lower early mortality thanks to Vyxeos, but they also were segued to and fast-tracked to bone marrow transplant, to allogeneic stem cell transplant. So it's kind of like a two-step dance that you have to take with Vyxeos. But it's also, like I said, very potent. Thanks to its mechanism of action, you're seeing now 60% MRD negativity, so you kind of get this super remission effect. But yes, it comes with a lot of side effects. It comes with a lot of infection risk, what we call febrile neutropenia. When you have low white blood cells and a fever, that's a medical emergency. So that's seen in almost 3/4 of patients. There's almost over 25% of patients get pneumonias. There's also bloodstream infections, bacteremia that can happen. Severe infections like sepsis can be seen in up to 15% of patients. And then because these chemos can also affect the heart, patients will have a kind of reduced ejection fraction when it comes to their heart and its ability to pump blood. So for the less fit patients who we think might not be eligible for Vyxeos, we'll now consider venetoclax. It's a therapy that will couple with those hypomethylating agents that I mentioned in the previous slides. And we've seen that these are a targeted therapy, so it's not that blunt cudgel. We know that AML cells express a protein called BCL2, and with venetoclax, it inhibits BCL2, and when you couple it with azacitidine or with decitabine, we're getting 2/3 complete remissions. The remission rates are almost that high, and actually at least a quarter of patients get into that MRD negative super remission. And we know that the longer patients stay on it, the more likely they're able to increase their eradication of this residual disease. So they're more likely to enter that super remission after about 4 to 6 months. And then we know that these are very durable remission rates. They last for almost 1.5 years. And if patients are MRD negative, so in that super remission, 3/4 of them at 2 years are alive and leukemia free. So and you can see here, this is the kind of how durable the responses are. Even after 2 years of follow-up, you see this plateau in the survival curves, which tells you that there's going to be a lot of long-term responders to therapy. And it tells it's a very durable therapy. And it's reasonably well tolerated. I mean, there are infectious risks. 2/3 of patients do get infections with this, but that's why it's very critical that patients are on anti-infective preventative antibiotics and antivirals and antifungals. 40% of patients will have severe blood cell counts or like low degree of cell counts that they might be at risk for transfusion. But overall, no serious functional compromises seen with it. Less than 5% of patients had any cardiac issues. In terms of severe nausea, vomiting, and fatigue, it's also less than 5%. So that seems to be like the new standard of care when it comes to patients who are deemed ineligible to chemotherapy with a venetoclax when you couple it with a hypomethylating agent. There's some other newer therapies on the horizon. We're seeing this one chemo regimen called FLAG-IDA and coupled with venetoclax. So it's like a cocktail of 3 different chemotherapies that we combine with venetoclax. We're seeing 90% complete remission rates. And of that 90%, 90% of them are in that super remission category, MRD negative. So it's definitely kind of one of the leading contenders when it comes to chemo-eligible, fit, younger patients with secondary AML. This trial that investigated this did not include patients above the age of 65, so it's very, I would like to caution that this regimen isn't the best tolerated when you consider patients more in their 60s and 70s with a secondary AML. And you can see here the litany of different side effects that happen. I mean, almost half of patients got some kind of severe infection or some kind of neutropenic fever. There's bleeding risks. There's also a lot of mucositis risks. So this is kind of what I call like the high risk, high reward game that you play with that regimen. There's also some targeted therapies that are available. I mentioned like there's a lot of different mutations that are involved in secondary AML. Some of these mutations are IDH1 and IDH2 that could be seen in at least 10 to 20% of patients, especially older patients. So now we have ivosidenib and enasidenib that are targeted therapies. And if in the first line setting, when they're coupled with a hypomethylating agent like azacitidine, we're seeing half of patients, almost 60% of patients achieve complete remissions. And the responses are usually around, the average response is about 14 months. So they're also very well tolerated. They're lower risk of infections, usually less than 20%. So a little bit better tolerated than venetoclax. And then lastly, there's allogeneic stem cell transplant. That's very important. This is the only curative option for secondary AML. After all, the issue with secondary AML is there's oftentimes a genetic predisposition that people have acquired in their lifetime that led to the problem. And if it's a very inflamed bone marrow microenvironment, a very toxic environment that is causing leukemia to be birthed, and kind of gain that survival advantage against the rest of your stem cells in that marrow, then you need a new bone marrow, or at least a new stem cell capacity in that bone marrow. So that's why allogeneic stem cell transplant is considered the only cure for this issue. And there's been retrospective studies out of Europe, in particular Italy, that have shown that whenever patients with secondary AML get transplanted, the median survival is as high as 60 months. But again, it's very contingent on patients getting treated, having as much of their leukemic disease eradicated, ideally achieving that MRD negativity, and then finding a donor and then transplanting that patient. Also, transplant is the ultimate high risk, high reward. There's a lot of complications that happen, including infection and graft versus host disease. It conveys a substantial non-relapse mortality, so dying from the transplant can be as high as 20%. And even with transplant, 40% of patients will relapse with their secondary AML, especially if it's like a therapy-related AML. It's about 20% at 5 years of people who are alive and relapse-free. So it's still a tough diagnosis, even with something that's potentially curative like transplant. And also patients have to be well enough to get into transplant. That's an important thing. So part of picking that therapy to induce a remission has to be something that minimizes side effects so it doesn't lead to enough functional compromise that patients then get deemed ineligible to transplant. If they get too many side effects from chemo or whatever treatment, they might not make it to transplant. So that's something that's important to come up with your doctor about achieving titrating that right balance between benefit and risk. And then if patients are fit enough, then taking them to transplant. So that's kind of my concluding remarks, is that it's very critical to achieve as much leukemic eradication and picking that regimen that confers the highest amount of benefit against risk. For the patients who are fit enough, they can be considered for like a chemotherapy plus venetoclax approach. That's something we're doing here at the Mayo Clinic. For older patients or patients who are deemed ineligible for chemotherapy, they could be considered for venetoclax and hypomethylating agents coupled together. If you're kind of older but a healthy older person and you have few comorbidities, you're going to also be considered a chemotherapy approach, but with Vyxeos as opposed to like the traditional 7+3 chemotherapies that we used to do about 10 years ago. And then now there's more targeted therapies that are on the horizon that can make secondary AML a thing of the past. And I think we're also using it for relapse refractory AML a lot. So these are the things that we're hoping, as we understand more of the biology of this disease and we figure out more of the genetic drivers behind it, we are now entering an era of more personalized medicine where we can pick a particular drug that combats maybe whatever mutational process that's behind the secondary AML. And then ultimately, if patients achieve a remission and if they're healthy enough, they should undergo allogeneic stem cell transplantation. And these are my references. Thank you. And any questions?
Thank you so much, Dr. Punwani, for the presentation. I'll start with our question from online. They'd like to know, are there some promising clinical trials happening for patients with secondary AML?
Yeah, I think there's a lot of there's a lot of clinical trials that are going to be opened up. I think some of the things that we're going to see is for TP53 mutated AML. I think that was one of the questions somebody asked in the earlier session about TP53. That could confer a very devastating prognosis in secondary AML or MDS. So that's something to be seen. Brenetapop is one example, and I think that's under active clinical investigation. So I think that's something that there's a real need for.
Okay, and now we're going to take some questions from the audience. Does anybody have any questions? Okay.
I believe you mentioned that once the blasts become under 5%, that there's a possibility that from the testing, you'll be able to see that.
Yeah.
At what time do you start treatment when you see them below 5%?
So if they're below 5%, so that's their post-treatment bone marrow biopsy, right? So they have to first have a diagnostic bone marrow. That's what leads to the diagnosis. Then you pick whatever treatment, and then you do the bone marrow biopsy, and then we see if it's under 5% or not. So then the question, that's at that point, a very dichotomous decision, right? The patient is in complete remission, and the decision has to be made, what do you do about it? Do you continue the current therapy, or do you take the patient to ideally an allogeneic stem cell transplant? So that it's a very dichotomous decision making at that time frame. There's some doctors that may want to, and this is something that you had to discuss with your patients, but you may want to continue the current therapy, especially if it's like venetoclax and hypomethylating agents. If there's still some residual disease, we know that post-transplant outcomes are maximized when you have as little leukemia as possible, ideally that MRD negative state. So you might want to continue the therapy longer. At least another 25% of patients become MRD negative after another 2 cycles on average. So that's something that there might be some extenuating circumstances that may warrant longer duration of the therapy before taking a patient to transplant.
Thank you. Any other questions from the audience?
Out of all the different therapy options that you talked about, are they being done here locally at this particular Mayo Clinic?
All of them, yeah.
Okay.
Not so much the flag Ida, because we've been having some fludarabine shortages, but we have something similar to it, the CLIA regimen, but generally same idea.
Thank you.
Thank you so much, Dr. Punwani, for sharing your time and your expertise with all of us. If you'd like to watch the session again and at a later time, it will be available on the conference platform within the next hour. You can just click replay or find the session on the on-demand tab. This session will also be available on our website within 7 to 10 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820. And you can also submit a question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. Our next educational session will start in approximately 15 minutes. This concludes our session.